Hello, everyone. I wanted to talk to you about diagnostic testing. So first, let's talk about why we do diagnostic testing. We said that when we do an assessment, we are collecting pieces of information to be able to make inferences or be able to make conclusions about a patient's information to lead us to something that might be a nursing diagnosis. Well, diagnostic testing is one of those pieces of the assessment puzzle. And they could be based on signs and symptoms of the patient that have led the practitioner to order a diagnostic test, or they can be a diagnostic test that is scheduled as a wellness check. So checking blood sugar or cholesterol or blood pressure, and then looking at normals versus abnormals to see if there is anything that is concerning for the patient's health. So we've got here that diagnostic testing is examined and combined with a patient's assessment data to identify and determine the severity of or evaluate the therapy effectiveness of a disorder or a disease. And that's another good point of we may be doing diagnostic testing. So let's say that we're doing, this picture is a chest x-ray. Let's say we're doing a chest x-ray. We may be doing it based on a patient's sign and symptoms, that they're short of breath and they have a productive cough and they have a fever, and the physician may want to see if they have pneumonia, so if they have excess fluid in their lung fields. So we may do an x-ray for that. But then let's say that they've had treatment in the hospital for 3 or 4 days and the physician wants to do another chest x-ray to see if the condition has improved. So if they have less free fluid, mucus, those kind of things in their lung fields. So we could be doing a diagnostic test inevitably to see if what we have done, the medication, the treatment, the therapy is effective, and comparing it to a baseline to where we're at now. We can examine different body parts for different indicators. So we could be looking at a picture like a chest x-ray or an echocardiogram, or we could be looking at lab work, which could consist of blood or mucus, sputum, urine, stool, and we can do diagnostic testing to see if there are any abnormal things found in those specimens that could indicate disease or a disorder as well. So the role of the nurse is to, again, depending on what type of a diagnostic test, we may be performing it. So we may be getting a urine specimen, we may be drawing blood, we may be getting a wound specimen, like fluid from a wound. But we may also, we also need to understand why it's being performed so we can tell the patient, and as well know what the lab tests are measuring so that we can look at the lab results and we can determine if they're normal versus abnormal and let the physician know, as well as see how that fits into our treatment plan with our patient. We have to understand all of that. And we may be communicating results, like we said, to other people. So we may be interpreting results for patients. So let's say that we check their blood glucose and it was 80, which is normal. And so I may be teaching my patient that their blood glucose was 80. And so that the normal range may be 70 to 110, and 80 was perfectly normal. And what that means in relationship to maybe they're diabetic, maybe they're not diabetic, but we also are going to be communicating the results of diagnostic tests to our practitioner. So what I mean by that is we want to be watching to make sure the diagnostic tests are performed, and that how our patient tolerated that and what the results are. So we're responsible that diagnostic testing is completed. We're advocating for the patient and seeing, has it been performed, whether we're doing it or someone else is doing it, and then test results that are things like x-rays or CT scans or specimens that are being looked at for bacteria. Those kinds of things, we are going to watch for the results, and we may be letting the physician know those results are ready, and the physician will interpret those results. So not all of our testing will have normal versus abnormal and be a number that we'll look at. It could be a chest x-ray where it says that there are some patchy atelectasis, or there is a nodule, or things like that. And that's for the physician to read the radiologist's interpretation, to be able to explain that to the patient. And we need to understand what that means as far as patient education and how we are caring for the patient as well. So let's talk about a blood specimen. First of all, if we think about a diagnostic test, one of the most common that's performed is a blood specimen. So what actually is in the blood? And we've got that a typical adult has about 5 liters of blood in their body at one time. And so that varies a little bit with male versus female. And blood volume, it says, is regulated by the kidneys. And so what that means is the regulation of fluid in our body, whether we're holding on to fluid that we need or we're getting rid of fluid, and fluid is a large part of what's in blood, is based on the kidneys. So we've heard of, and we'll talk much more about the renin, angiotensin, aldosterone system, which is hormones that stimulate us holding on to fluid to support the cardiovascular system, or when our body has too much fluid, urinating and getting rid of that fluid. So the kidneys have a big part in that. They also play a huge part in development of blood cells. They produce something called erythropoietin, and erythropoietin is necessary for the development of red blood cells in the bone marrow. So if our kidneys aren't functioning properly, they wouldn't be able to produce that erythropoietin adequately, and they wouldn't be able to regulate the amount of fluid balance that we have in our body. And so truly, when we're looking at a lab value, whether we're talking about white blood cells or platelets or glucose or anything like that, we're looking at the amount of those products in comparison to the fluid. So it's a concentration of what we're looking at. If there's too much fluid, the things like white blood cells or platelets or glucose or potassium or whatever we're looking at can look very low. It can be diluted by the amount of water. But if our patient is dehydrated and they have less fluid, the number of those things compared to the amount of fluid can look very, very high. So it's important that we assess fluid balance of our patient when we're assessing labs. And we're going to talk a whole lot more about that when we talk about fluid and electrolyte balance. So what's in the blood? First, a large part of the blood is plasma. And like it says, it's the liquid portion of blood. And if they were to spin out the blood in some type of a laboratory machine, it would actually separate like we have here, and it would separate the plasma part from the blood cells. And what's in plasma are proteins. They're also some of our electrolytes, our glucose, amino acids, vitamins, proteins, fats. These are the things that are used for energy. And these are the things that are transmitted in the blood and taken to the cells to function as energy. One of the important things that's in plasma is a protein called albumin, and we'll hear a lot more about albumin. And so albumin's job is, as a protein, is to carry along some of those things like glucose around the cells and drop it off. But it's also a job, his job is called an osmotic stabilizer, which means that albumin helps to hold the blood in the blood system, in the vascular system. And that's important because we need the fluid in the blood cells and everything in the vascular system, the blood vessels, to circulate around the body. If our albumin is low in the plasma, then what happens is all of those things, particularly plasma, which are very, very small, start to leak out of the vascular system and they go into other tissues. And that's when we see edema in patients. It could be edema in the abdomen, around the ankles, the face, the sacrum. And so that could indicate as well that we aren't making enough albumin. And what is albumin? It's a protein. And so our nutritional status is important to producing proteins such as albumin. And so if a patient is malnourished, we can see problems with not only the amount of nutrients getting to the cells, but the important part of those nutrients going out into other places in our body where they're not useful to us. And that puts a lot of work on the heart and the blood vessels to be able to pump that smaller amount of blood to get around to where we need it to be. So making sure everything is in adequate amounts in the vascular system is extremely important. As we've talked about, it's a pretty complex process. So the normal structure and function of blood cells, we're going to talk about really the three main blood cells. And when we say blood cells, these are produced in the bone marrow and also the spleen, and they have very distinct functions. The erythrocytes are red blood cells, and we know that primary responsibility of red blood cells is to carry oxygen around the body. And so not only do we look at the number of red blood cells in all of the blood cells, but we look at some descriptors of what is going on with the red blood cells. For example, we look at hemoglobin, and hemoglobin is the amount in the red blood cells that determines their oxygen carrying capability. So I want to know how much oxygen the red blood cells can carry. And we're going to talk about some types of diseases and disorders as we go along in the program that really make red blood cells misshapen or make them not as effective to carry oxygen. So simply just looking at the number of red blood cells doesn't truly tell me about what they're able to do. So I have that descriptor, which is called hemoglobin, that tells me about their oxygen carrying capabilities. I also have hematocrit. And so hematocrit is the proportion, it's a percentage. That's what I wanted. It's a percentage of the amount of red blood cells when compared to other red blood cells. So we think, is this important? Yeah, it can be. And so not only do we need the total number of red blood cells in that specimen, but with hematocrit, we can say, okay, I have a total number, but how does that compare to the percentage of red blood cells that are in all of the blood cells? So red blood cells, white blood cells, and platelets. And that can tell me if I am producing the quantity compared to the thrombocytes and leukocytes that I need to do the job of the red blood cell. So we have total number of red blood cells in red blood cell count. We have hemoglobin, the oxygen carrying capacity in the red blood cells. And then we have hematocrit, which is a percentage of all the blood cells of the red blood cells that make up all of the blood cells, okay? Then we can look at thrombocytes. A thrombocyte is a platelet, and platelets are important for blood clotting. And so we can look at the body's ability to clot the blood if we have bleeding, and bleeding particularly of the blood vessels. So all of these blood cells circulate in the blood volume, so they can be readily available to any area of the body at any time. Now with platelets are the first responder for blood clotting. There are a number of clotting factors in the body, and that's important. But platelets are really the first ones that come to the scene if there is a damage to the blood vessels and we're bleeding, and it helps to begin forming a blood clot. Okay, so it's important that we have not only platelets that can get there in a hurry, but we have the adequate number of platelets to form those blood clots. And then it forms what we call a coagulation cascade of when we have initiated those platelets and they've started a plug at an area where there's a bleeding, that other types of clotting factors are then released. Leukocytes are white blood cells. And so we think about white blood cells as two factors. They are indicated, we use them during inflammation and during infection. So we'll kind of talk about in a minute what's it mean if there's too much or too little of all these, but knowing that white blood cells respond not only to infection, but inflammation. So there can be a usage or an elevation of white blood cells in an inflammatory process. So just like we said, there are descriptors of red blood cells. We also may have questions about white blood cells, because we said they do a lot of things. They respond to infection, inflammation, allergies, anything like that. And so if there's a question about the red blood cells, let's say we have too much or too little red blood cells, or the physician suspects some kind of inflammatory process or infection, he may order what's called a white blood cell differential. Or he says, I not only want the number of white blood cells, but I want to look at all the different types of white blood cells because they each have a different job. For example, neutrophils are the first offenders. So if there is some type of a foreign invader or inflammation or infection, then neutrophils are the first one that are there. They're also the most numerous. And so I think of most numerous with the N in neutrophil. And what that means is there's more of them in proportion to any of the other white blood cells. So for this, if we're looking at 100 white blood cells, 55 to 70, that percentage would be the number of neutrophils because we need them. They respond quickly to any type of potential invader, and that could be infection or inflammation. And so we use them very quickly. Lymphocytes, they are used to build an immune reaction. So they recognize a foreign invader, they form a memory of something that's a foreign invader, and they produce antibodies. And we're going to talk much, much more about lymphocytes coming up. But what I tend to think of with lymphocytes is whether I'm exposed to a disease process or I get an immunization, the lymphocytes are really what are going to identify something that's in our body as foreign, and then they take a picture of it so that the next time I encounter it, I maybe have built up some immunity, which will protect me, or I can act quicker to identify what it is and be able to fight it faster. Monocytes are involved in what's called phagocytosis. So after the neutrophils identify something as a foreign invader and they start to destroy it, the lymphocytes come and they really help to destroy it and kind of gobble it up and eat it up and help our bodies to get rid of it. Eosinophils destroy parasites, and they're also involved in allergic reactions. So many times if somebody has an allergic response to something, let's say we're allergic to peanuts and we've been exposed to peanuts, or even seasonal allergies and sneezing, asthma gets worse with certain environmental pollutants, they can draw a white blood cell count and look at eosinophils and say, are the problems they having an allergic response? And that could indicate maybe that they could get allergy shots, or we could teach them how to avoid an allergen, all those type of things. But eosinophils are going to be elevated when we are having an allergic response to something. And then basophils are also involved in the inflammatory response. So they release what's called a histamine. And those histamines are what kind of give us the reaction that our body is fighting something. So a histamine could give us, let's say if we're exposed to, I don't know, pollution outside. So let's say that it's high pollen or mold or things like that. The basophils are what are going to trigger our response. So maybe I have an itchy nose and sneezing, or itchy eyes and cough. And it's really our body's response to be able to get rid of those things that may be causing those symptoms. So if I'm exposed to things, if I'm breathing them in and they cause me to have some type of an inflammatory reaction, the sneezing and coughing and runny nose and itchy eyes are my body's way of getting those things out of my system. Okay. So then we said we're breaking really apart the plasma. It's the liquid portion of the blood, and there's a whole lot of things in there. I think about it as the nutrition that needs to get to the cells, the electrolytes, and we're going to talk a whole lot more about electrolytes that help to help our muscles function and our neurological system function and build strong bones and muscles and teeth. And then also proteins that are carrying nutrients, as well as transporters that carry other things around our body needs, like glucose. And there's also hormones in the blood, things like thyroid hormone, estrogen, progesterone, testosterone, all of those types of things, because hormones, that's how they travel from one part of the body to another. Many times one part of the body makes a hormone, but it has to really fit into a receptor at another part of the body. And so it travels through the vascular system to that part of the body. And then we also have waste products, and the most common waste product that we can think of is carbon dioxide, right? So we take oxygen to the cells, they use it, and they put off a waste product called carbon dioxide, and it's transported back to the lungs at the alveoli. We have that gas exchange, and then we exhale our CO2. So that waste product is also being carried around the blood system and back to the lungs for us to get rid of. So let's look at a couple of common blood tests. And really, I want you to know what they are and what they measure. We'll talk much, much more about them, of course, when we get into different body systems. So this is really an introduction to talking about what kinds of laboratory tests are really out there and why would we use them. The first one is called an arterial blood gas, and an arterial sample. So in this slide, I'm talking about where do we get blood from? Do we get it from the artery, which carries oxygenated blood, or do we get it from the vein, which carries deoxygenated blood? We would think that we might get red blood cells and look at the number of red blood cells in oxygenated blood. But the thing is, we're not looking at the amount of oxygen that's in the red blood cells. We're looking at their ability to carry oxygen. So we usually get blood from a venous sample from a vein, because they're more accessible to the skin, as well as we can look at a whole lot of other products in the vein without taking a portion of oxygenated blood that needs to get to the cells, right? So most of our products that we're going to be testing on, most of our blood tests we use a venous sample. The exception to that is an arterial sample. And the only thing that we really get a sample from an artery, and that's really from the wrist, is looking at an arterial blood gas. And so what I want you to remember about that is we're really looking at how much oxygen as well as carbon dioxide is being carried in the blood, okay? Now, a venous sample, we said we can look at information on oxygen and carbon dioxide. And with that, the red blood cells, we're looking at the carrying capacity of those red blood cells. So what shape are they? What do they look like? How big are they? And we're also looking at information on immune and inflammatory response. So we're looking at the white blood cells, how many there are, what types there are. And we're looking at the clotting factor, and we can get all that specimen from the venous sample. And so looking at red blood cells, white blood cells, and platelets is called a complete blood count, or a CBC, okay? This is an example of a CBC, and I've given you some reference values here. They're a little bit different than the ones in the book, and so an important thing to talk about here is that each lab is going to have a little bit different, what we consider reference range of what normal range is. And that is going to be what that laboratory follows. An important point is when we get our laboratory values, let's say we're at a physician's office or at the hospital, our numbers that we get for this patient are going to be presented as well as the reference range of what's normal for that laboratory. So we're always going to have the patient's numbers and the reference range when we're getting a printout from the lab results. So what I want you to concentrate on at this time is remembering the number of white blood cells for an average adult reference range, 4.5 to 11,000. I think our book may say 4.5 to 10.5. So that would be an adult reference range. Red blood cells, the number of red blood cells, male says 4.5 to 5.5, and females say 4 to 5. So we could say that there's a reference range there from 4 to 5.5, truly. I'm not going to ask you the difference in male and female, just knowing that they're a little bit different as far as the concentration of blood that our body carries. But I would say the reference range would be 4.5 to 5.5. And again, the book may be a little bit different, but that's okay. Hemoglobin, again, is talking about the oxygen carrying capacity in our red blood cells. And I would say this reference range here would be 12 to 17. Again, there is a slight difference in male and female, and we're going to be looking at that of male versus female if we have a printout in front of us of the lab results. But simply for remembering, I would say that reference range would be between 12 and 17. Okay. Hematocrit is the percentage of red blood cells among all the blood cells in the body. And again, our reference range is a little bit different. So we could even say maybe 36 to 50, 35 to 50. And again, knowing that reference range is going to be a little more specific for male versus female. The MCV and MCH, MCHC, RDW, MPV. I'm not going to ask you really to remember all those right now, or I'm not going to get too specific on even what they are right now. We'll talk about them later. Basically what they are is, M is the mean corpuscular volume, and it's talking about how big the red blood cells are. Some disorders have produce red blood cells that are very, very small, and some produce red blood cells that are very, very large. And so that can affect their ability to be able to carry oxygen. The mean corpuscular hemoglobin, MCH, is talking about the size of the oxygen carrying capacity. So again, there are more descriptors of red blood cells, and then the MPV is mean platelet volume. It's a descriptor of platelets. So we can look at as much detail as we want. And basically what that's for is because when we see something that's abnormal, we want to know more details about it, right? So if I see that the hemoglobin in red blood cells is too high or too low, I might ask another question about it and say, wow, is that the amount of hemoglobin that's actually being carried, or is that the size and the distribution of the hemoglobin? So that enables the physician in the lab to really look more in detail and say, when we're looking at these under a microscope, these are some more details of what I'm seeing. Platelets has a value of 150 to 450,000. And so knowing that that amount of platelets is normal for an adult. So I want you to remember white blood cells, red blood cells, hemoglobin, hematocrit, and platelets, and know those values and know what they are measuring. I put this lab in here because it shows the CBC with differential, or it shows as in comparison to a regular CBC. This one shows all the different types of white blood cells. And so I just wanted to give you an example. If a physician was getting a CBC, but they said, you know what, I'm concerned about infection or inflammation, get the differential as well, which means that they're going to give me more details on the white blood cells. And so I still have my white blood cells, my red blood cells, my hemoglobin and hematocrit. And then if I skip it down, I have my platelets. But I also have more details below that about the white blood cells. So for example, right below platelets, we have neutrophils, lymphocytes, monocytes, eosinophils, and basophils. And if we look at the values of that, it goes from 47 down to 1. And these are a percentage. So adding up all the percentage of white blood cells there equals 100%. And we can see that 47% of those are neutrophils, which should be the most numerous. So it tells a percentage of each one of those white blood cells in that blood sample. Below that, there's absolute values. So we've got neutrophils, lymphocytes, monocytes, eosinophils, basophils, and it says an absolute value. So instead of saying, well, let's look at the percentage of neutrophils, maybe in that specimen, I want to say, it's important I know the percentage, but I want to know exactly how many are in this sample. And that's what that shows. It shows the absolute number in that sample. So again, it's just a different way of describing the white blood cells that may help the physician or laboratory distinguish one type of disease process from another. So what are we, let's look at the blood tests. We're concerned about blood vessel injury. When we're doing a lab test, we have to understand that that's what we're doing. We are inserting a needle into the blood vessel. And so that blood vessel, when we insert the needle into that, we're taking a sample of blood. And then after we withdraw the needle, that the platelets go into effect and produce a clot there, as well as call out other types of clotting factors to make a clot. So we have to remember that if we have patients that are on some type of a blood thinner, that they could have more bleeding than other people. So monitoring the site after we give an injection, after we draw blood, to make sure that there's no continued bleeding is very important. And what you might see is someone that is more prone to bleeding for a longer period of time. They may put a bigger dressing or a bigger bandage on where they've drawn blood. They may have the patient hold pressure on it. And all of those things are to help with clotting. So what happens when blood vessels are injured? There is a spasm at the area. And so what that means is it is telling the body that there's an injury, and that calls on the platelets that are circulating in the vascular system to kind of pool at that area and form a wall or a clot to prevent any blood from leaking out of that area. And then after that platelet kind of plug is formed, then they call on all the other types of clotting factors that are produced in the liver to come to make that a permanent, better clot there. And then the body heals over that injury. So it's important that we have the adequate amount of platelets to go to the area very quickly, and the adequate amount of other types of clotting factors to ensure that that is a very stable clot and that the body heals itself, because after that clotting, the body understands that the healing process has to take place. There are a lot of type of clotting factors, and again, we'll go on to talk more about them. I just wanted to kind of emphasize that platelets are the ones we're really measuring with a CBC, and they are the ones that are going to act most quickly. So having the adequate amount of platelets is very important. Other tests we may do to look at clotting factor could be, like we said, the amount of platelets, but we could also be looking at the bleeding or clotting time, so how quickly it takes for that clotting to happen. We may look at what's called a prothrombin time. So not to get into too much detail right now, but there are different types of clotting factors and different what we call clotting cascades. So different types of clotting factors for different types of injuries and things like that. So we may be looking at how long does the body take to clot using one type of clotting factor versus another type of clotting factor. We can also look at the individual types of clotting factors and if there are deficiencies in those. And so if someone has a problem with bleeding and we've looked at platelets and platelets are normal, they're going to go and look at the other types of clotting factors as well. So this question says, which of the following phrases describes plasma? We've got formed elements in blood, platelets, fluid portion of blood, or electrolyte-free portions. What do you think? It's actually C, the fluid portion. So why the others would not be correct is A says formed elements in blood. Plasma is liquid. It wouldn't be platelets because platelets are blood cells. They're not in the liquid portion. And then it says electrolyte free. Platelets are what carries the electrolytes. Okay. So let's look at another laboratory test. It's called a blood chemistry. And so sometimes you may hear it called a basic metabolic panel or a complete metabolic panel or a CMP or a BMP. Basically, they're blood chemistries, and that's all I want you to know right now. So blood chemistries look at something different than the CBC, the complete blood count. Complete blood count, we said, was looking at red blood cells, white blood cells, platelets, and then the descriptors of those. Blood chemistries are looking at the other things that really are being carried in blood, and we think that that's in the plasma portion, right? So we're looking at electrolytes, and we're going to learn about what all the electrolytes do. We're looking at glucose. We're looking at the amount of how the liver functions, the kidney functions. So some of those products that are put out that may be waste products. Okay, so we're looking at things that are involved in the plasma, and those are important. Another test that's specifically looking at glucose, as opposed to taking a blood sample and saying, this is how much glucose is in this sample of blood at this minute, is looking at glucose levels from an extended period of time. So hemoglobin A1C is a little bit different, and I don't want you to get it confused with hemoglobin. So that's why I kind of put it in here as well. I want to talk about the difference. A hemoglobin A1C is glycosylated hemoglobin. And so what it is glucose is carried around in the plasma at about the same rate as hemoglobin, the red blood cells. And red blood cells last about 120 days, and then they die off and we have more. And so that's kind of our glucose carrying capacity as well. So we said that red blood cells live about 120 days. Well, we're looking at glucose levels in the blood for about 120 days. And we think, why is that important? Well, it's important that we get a different look at glucose other than just drawing blood today. And I say right now at 11:45, this is what my glucose is. And that's important. But we also want to say for the past 120 days, so let's say the past 4 months, what has been the average of my glucose? And that's important to say, how long has this patient maybe been diabetic? Or how long has this patient had improved glucose? Or if my patient has taken new medication or has done a new diet or something like that, how effective has it been over these 120 days? So I'm getting just a different picture of glucose in my patient's life. And so I don't want you to remember the values of hemoglobin A1C right now. I've got them on here for a reference range, just to compare with glucose in general. If I'm looking at sticking my finger or getting a blood sample of glucose at this minute at 11:45 today, maybe it's after I've eaten lunch and it says it's 140. But that's just one moment in time. This is telling me the percentage of hemoglobin that is still hanging around in my body after this 120 days. So we want the number to be lower to be good for our patient, of saying that the percentage of hemoglobin that is still circulating in the blood after 120 days is not high, because if we have glucose circulating in the blood for 120 days, that means that our body doesn't know what to do with it. There's too much sugar. We're not using it enough. And so we're taking in more than we're using, and that's not good for us. So for hemoglobin A1C, patients without diabetes, they say 3 to 5. And really what the American Diabetic Association says is that they want someone who is diabetic, or to look at if someone is diabetic, we say that we want their glucose below 6.5. If it's below 6.5 on 2 occasions, then you're not considered diabetic. But if it gets above 6.5, then your body is having difficulty regulating insulin and glucose. So this says diabetics under control is 7 to 11. I think 11 is really high. So again, according to the American Diabetic Association, we think for someone really to be considered diabetic, it's over 6.5. But then understanding that as we're regulating medications, lifestyle, exercise, diets, those type of things, we would hope our glucose, if we're diabetic, would maybe start from around 10 or 11 and go down to about 7. And 7 would be a good number to kind of manage that, 6.5 to 7. And then patients who are elevated, I would even say 10, 11, higher, are not in good control, which means that they're even after treatment, even after changes in diet, or maybe the patient's just not understanding or compliant, that their glucose is still really, really high. And these help us to estimate the patient's likelihood of having peripheral vascular disease, so damage to the blood vessels, having a stroke, having a heart attack. And these numbers can really tell us if the treatment we're using is helping to have the glucose circulating in the blood under control over a couple of month period. And I've just got an example of a what we consider to be a chemistry panel. This is called a complete metabolic panel. And I just wanted you to see what's in there. It's got glucose. BUN and creatinine are waste products that are produced from breaking down things like proteins. Again, we have waste products circulating in the plasma that we're taking to get rid of. It also has our electrolytes. It has our albumin that protein that holds fluid in the vascular system. Another protein is globulin, and then AST and ALT. Those are percentage of kind of waste product produced by the liver. And so those are things that are found in a chemistry panel. We can see they're much different than things that are found in a CBC. They're all in a blood sample, but this is more of what's found in the plasma part, and a CBC is what's found in the blood cell part. So some other types of lab tests. So what other things can we look at when we look at the blood? We can look at samples of cholesterol. So we can do what's called a lipid panel. We can look at total cholesterol, low density lipoproteins, high density lipoproteins, and triglycerides. And they're very important to know the amount of kind of fats that we're taking in and how we're breaking those down. And really looking at the comparison between the fats that I need, which are important for building fat stores and for breaking down cholesterol. But also, are we getting too much cholesterol or too much of a bad kind of cholesterol that can damage the blood vessels? So this is not only looking at the total cholesterol number again, but descriptors of that. The good cholesterol, the not so good cholesterol, and then really the trans fatty acids, those triglycerides, which are very hard for the body to break down. And so I know we looked at some samples of the numbers and what those numbers mean. We're going to be building on that more and more as we go along. Here's an example of a lipid profile. So again, this is from the American Heart Association, and it's important to let patients know where their numbers are as far as health, instead of saying that's normal or abnormal. What's that mean? So this is showing our total cholesterol, triglycerides, HDL, LDL, and then they can get a ratio or a range at the bottom of good versus not so good cholesterol. But our total cholesterol, we want below 200, triglycerides below 150, HDL, we want at 60 or greater. And that's really for females. The HDL, females really should have more than males. And then LDL, we want 130, or some places say 150 or below. And so again, we can see that it's important not only for me to say, is that in the normal range, but if I'm not in the normal range, where am I? Am I borderline, which means that I'm a little bit elevated, which is still very serious. And that means that we're going to talk about diet and exercise and making good food choices. Or am I in the very high risk where we talk about those lifestyle changes, but say, it may be important as well that we maybe go on a cholesterol medicine because I'm at a higher risk of having things like a heart attack or stroke, the higher that my lipids are. So quick quiz, which lab value on a lipid profile is considered the good cholesterol? And so the good cholesterol, I think about the number that we want to be elevated to be good, and that's high density lipoproteins. And that number, that type of lipoprotein, or what's broken down in good cholesterol, is a protective protein. And so what it does is it helps to pull some of the triglycerides and low density lipoproteins out of the body before they're absorbed into the bloodstream. It also helps when it gets into the bloodstream to get some of those not so good cholesterol and take it to the liver to be broken down instead of it continuing to circulate in the blood system. So we want our HDL to be higher rather than lower. And one of the things I kind of mentioned in class was that HDL is really genetic based. I mean, it can be influenced somewhat by medications and diet, but it really has a genetic predisposition. So if my parents had good HDL, I probably will. If they had bad HDL or not so high HDL, then I probably will have lower HDL. So we really focus on decreasing the amount of total of the triglycerides and low density lipoproteins in our diet, and concentrate on getting things like unsaturated fat, polyunsaturated fats, which are good types of cholesterol in our diet. So teaching patients the difference between the types of cholesterol and why certain types of fats are good, that we need them as a protective layer in our body, but the ones that are not so good really build up in our blood vessels and can cause things like atherosclerosis or heart attack or stroke.